Acute coronary syndrome, or ACS, is the term used for unstable angina, a NSTEMI, which is a non-ST elevated myocardial infarction, or a STEMI, which is an ST elevated myocardial infarction. This means that there is myocardial cell death and a cardiac enzyme called troponin is released. This differs from unstable angina, where troponin is not released after the onset of chest pain, and the ECG may appear normal. A transmural infarction means that the area of necrosis extends through the thickness of the heart muscle from the endocardium to the myocardium to the epicardium. As NSTEMIs are non-transmural, the area of ischemic necrosis does not extend through the full thickness of myocardial wall. The cause of acute coronary syndrome is down to atherosclerotic narrowing of the coronary arteries. The common mechanism for all acute coronary syndrome is the rupture or erosion of the fibrous cap of a coronary artery plaque, where a platelet-rich clot forms and vasoconstriction is produced by platelets releasing serotonin and thromboxane A2. Risk factors can be split into modifiable and non-modifiable categories. Modifiable risk factors are smoking, diabetes, hypertension, hyperlipidemia, which is high cholesterol, and obesity. Non-modifiable risk factors are increasing age, being male, and a family history of ischemic heart disease. The most common and important symptoms for acute coronary syndrome are acute central chest pain lasting more than 15 minutes, pain that radiates to the arms, jaw, neck, or back, dyspnea or shortness of breath, nausea and vomiting, sweating, restlessness, palpitations, and silent acute coronary syndrome can occur in those with diabetes or the elderly where there is no chest pain. The clinical signs of acute coronary syndrome are signs of heart failure, such as an increased jugular venous pressure, a third heart sound, or basal crepitations in the lungs. Other signs include feeling anxious, pale, cold, bradycardia or tachycardia, and hypotension or hypotension, a fourth heart sound, or a pansystolic murmur, which may be due to papillary muscle rupture or a ventricular septal defect. To investigate acute coronary syndrome, we carry out some blood tests, such as full blood count, urea and electrolytes, glucose, lipids, and cardiac enzyme tests of troponin and creatinine kinase myocardial band, or CKMB. These will help distinguish between unstable angina or a myocardial infarction. An electrocardiogram or ECG can be done at the bedside, and ECG changes may be seen as follows. In a STEMI, you'll see tall T waves, ST segment elevation, or new left bundle branch block occur within hours. T wave inversion and pathological Q waves may develop over hours to days. In an NSTEMI, you might see ST depression, T wave inversion, or non-specific changes. And in unstable angina, the ECG may appear normal. A chest X-ray can be done, which may reveal cardiomegaly, pulmonary edema, or a widened mediastinum due to aortic rupture. An echocardiogram may reveal regional wall abnormalities and a reduced ejection fraction, and a coronary angiogram can be done to check the artery blood flow. To appropriately manage acute coronary syndrome in the emergency setting, we can follow these steps remembered by Mona. Morphine, IV, and an antiemetic can be given, such as metoclopramide. Oxygen, if saturations are less than 94%. Nitrates, glycerol trinitrate spray or sublingual tablets. Aspirin, given orally as a loading dose. For a STEMI, which we will know by checking the troponins and ECG, we will use percutaneous coronary intervention, or PCI, if it is available within 120 minutes after presentation and the symptoms are still present. We'll also add a second antiplatelet, such as clopidogrel or ticagrelor. We could add IV nitrate if pain continues. Fondaparinux or low molecular weight heparin is given prior to PCI. If artery revascularization by percutaneous coronary intervention is not viable, then we can give alteplase IV followed by coronary stenting. For an NSTEMI or unstable angina, we can use the GRACE score. This is calculated for a 6-month mortality risk and is classified into low, intermediate and high. Low risk, which is less than 1% mortality, means patients will require non-invasive testing and lifelong aspirin. Intermediate risk, which is 1 to 3% mortality, means patients will require angiography within 3 days and dual antiplatelet therapy. High risk, which is more than 3% mortality, means patients require angiography within 24 hours, dual antiplatelet therapy, and coronary artery bypass grafting will be considered for these patients. After a myocardial infarction, medications are given to patients to take home for secondary prevention. These can be remembered by ABCAS, an ACE inhibitor, beta blocker, clopidogrel, aspirin, and a statin. In summary, we have covered the definitions of acute coronary syndrome and their differences, the causes of acute coronary syndrome due to blockage of the coronary arteries by atherosclerosis, the risk factors such as smoking, age, obesity, and a family history of ischemic heart disease, signs and symptoms, some of which are acute central chest pain, nausea and vomiting, shortness of breath, and murmurs or palpitations, investigations, ECG to help identify the type of acute coronary syndrome between STEMI and NSTEMI, blood tests such as cardiac biomarkers of troponin and CKMB, chest X-ray and coronary angiograms to find the blocked coronary artery. Management, acutely done by morphine, oxygen, nitrates and aspirin, the use of percutaneous coronary intervention for a STEMI, and calculation of the GRACE score for an NSTEMI or unstable angina with the following management. Thank you for watching. Be sure to share the video if you found it useful and keep up to date on rekapmed.com.